So we are live now. Sujaya?
I'm here. I'm very much here.
Yeah. So welcome to this 42nd episode of Searchlight. This time, the Searchlight is on cardiac disease in pregnancy. The program is sponsored by Cancer Prevention and Relief Society in association with faculty from Bhimavaram, Bhopal, Jabalpur, Jalandhar, and Raipur Obstetric Gynec Society. We have two very great speakers, Dr. Lakshmi Seshadri ma'am from Vellore and Dr. Reena Wani ma'am. And the convener for this program is Dr. Sujayasri Sangita. She is the secretary of Bhimavaram Obstetric Gynec Society. She is consultant obstetrician and lab surgeon at Seshadri Hospital, Palakol, and Malkapuram, founder secretary of Bhimavaram Obstetric Gynec Society, secretary IMA Palakol. She has Shan S. Ratnam, Young Gynecologist Award. She also has the Foxy Dhira Award. Her areas of interest are laparoscopy and infertility. She has paper presentations at multiple conferences, has organized academic events, and conducts awareness program Vikasam for adolescent girls. She also has received recognition by the District Lions Club. Welcome, Sujayasri.
Thank you, ma'am. Thank you for this kind words of introduction. So now it gives me great privilege to be introducing the program director, Dr. Asha Jain, ma'am, who actually needs no introduction. Her current post, sir, she's the director of SMSA Hospital, Raipur, medical director, Cancer Prevention and Relief Society, elected member, CG Medical Council, chairperson-elect Foxy, Food Drug Medical Surgical Equipment Committee, president, Raipur Menopause Society, chairman, Mission Pink Health, IMA Raipur, and executive member of various organizations. She has received colposcopy training, certification for IOTA. Ma'am's areas of interest are preventive oncology, colposcopy, saving the uterus, fetal medicine, obstetric and gynec ultrasound. I request ma'am to please proceed with the invocation.
Going forward, we pray to the divine before we start the program. I hope everyone joins me now in invocation. Our guest, Dr. Abha Singh ma'am, is traveling and she has not been able to join right now. My coordinator is Dr. Purvi Agrawal, who is the SFM executive from Raipur. I would like to introduce the chief guest, Dr. Abha Singh ma'am, who's the Vice President, North Foxy 2025. She has been awarded the WHO Fellowship in Infertility in 2000, Dr. C.L. Zaveri Endowment Symposia, Dr. S.B. Khanna Oration, Enlightening the Path for Next Generation, Leelavati Ghai Oration at Maternal and Child Health Government of India Initiative, Inspiring Gynecologist of North India, Champions of Foxy, and Gold Medal in Paper Presentation. She is an MS FICOG, FICMCH Gold Medalist. She's currently Professor Obstetrics and Gynecology, ESIC Medical College, Faridabad. She is VP-elect North Zone, past Chair Medical Education Committee Foxy 2019 to 22. She's organized successfully Dr. C.G. Saraya CME at AICOG in 2020 and 2021 and 2023. She is past President AOGD, Honorary Secretary AOGD, has various positions in AOGD, Chairperson DAC PCPNDT, Chairperson Safe Motherhood Committee, VP Delhi Gynec Endoscopic Society. She has delivered many guest lectures, orations, and her fields of interest are high-risk pregnancy, laparoscopy, infertility, and oncology. We will have Madam when she joins in. Now, as Dr. Reena has a guest at home, I would request Dr. Sujayasri to please introduce Dr. Alka Agrawal ma'am, who has joined in as our chairperson. And then Alka ma'am will introduce Lakshmi ma'am and we'll take the program forward.
I would like to introduce Dr. Alka Agrawal ma'am. She is the president of Jabalpur Menopause Society. She has been the past president of Jabalpur OB-GYN Society for the year 2019 to 2020. She's the vice president IMA Jabalpur branch for 2022-23. She's been the organizing secretary recipient of national award, and she has other. Ma'am, can we have She's also been a recipient of a national award for Pradhan Mantri Suraksha Matrutva Abhiyan, and Madam has also won the Wonder Foxy Award in 2019. So she has a lot of awards to her credit. So it's a great honor to have you with us here today, ma'am. I would request you to please introduce the speaker, Dr. Lakshmi, ma'am. Ma'am, Dr. Alka Agrawal, ma'am.
I cannot.
Yeah, she's logged in, but she's not.
But yeah, so I think I will introduce Lakshmi ma'am.
Yeah.
So, respected Lakshmi Seshadri ma'am is a former professor and HOD, Department of Gynae, CMC Vellore, former senior consultant gynae at Tirumalai Mission Hospital, Ranipet, Vellore. She has more than 50 publications in index journals, chapters in textbooks, authored textbooks, Essentials of Gynecology. Three editions have come up, 2010, 16, and 2022. Essentials of Obstetrics 2015-20, and the new one is just getting ready. So we are really honored and blessed to have such a speaker with us. She has several orations awarded in various conferences. Her areas of interest are gynec oncology, menopausal medicine. She has done screening for cervical cancer with VIA in 9,000 cases and screening and management of NCD in a rural population. Welcome, ma'am. We are really, really very honored to have you with us and requesting you to please take the program forward.
Thank you. Thank you, Dr. Asha. Without wasting much of your time, I shall start with my talk. Right. Slideshow. Okay. Rheumatic valvular disease in pregnancy. Why is it that the color has changed and I'm not able to move it? Any particular problem? Okay,
Yeah, ma'am, it's moving.
it's moving. Okay. Now, I'm not able to get a
Ma'am,
slide.
below the,
Yeah, I tried that.
ma'am, go up and do the slideshow
Yeah,
then.
that is what I'm doing, slideshow. That also is actually. Can I just present it like this, or is it too
Yeah, ma'am.
difficult to
Go
read?
ahead.
Okay.
Otherwise, you could just stop sharing and share again. Sometimes it gets better with that.
Okay. Okay. It's coming up. Am I okay there, or what has
Ma'am,
happened?
share again.
Okay.
Ma'am, now you can share it once again, ma'am.
Let's go up.
So I close that.
Funny.
Screen. Yes. Okay. Is that okay now?
Ma'am,
Can you?
perfect.
Ma'am,
Okay. Okay. Right. Yes. Okay. I have been given 20 minutes, and I'll try and finish it as quickly as I can, because it's an extensive topic. Somebody was supposed to speak before me on congenital cardiac disease, and so in order not to overlap, I had actually planned to go rapidly through some of these classifications, especially the WHO classification, etc.
Ma'am,
So
you
I may.
can take more than 20 minutes, no issues.
Okay. Okay. Sure.
Relax, and our audience should actually understand the subject when
Okay.
they have such an expert as you to listen to.
Fine. Thank you. Thank you so much. So I will be dealing with rheumatic valvular disease in pregnancy. Starting with the epidemiology, you can see that by the 1960s, the overall prevalence of rheumatic heart disease was waning in the high-income countries. The proportion of women with congenital cardiac disease started to increase. But unsurprisingly, this decline was not shared by low-income countries, where this enormous burden of rheumatic heart disease still persists, and the highest prevalence is seen in India, China, Pakistan, Indonesia, accounting for almost 73% of global cases. So even though the rest of the world is moving, we still are seeing a lot of rheumatic cardiac disease, though in tertiary centers like ours, we are seeing a little less, but I'm sure in rural areas, we do see much more often. There are some basic facts that we need to remember about rheumatic cardiac disease. Mitral stenosis, it is a disease of poverty. Mitral stenosis is the most common heart lesion. Women with mild asymptomatic mitral valve disease tolerate pregnancy well with very few complications. Mitral stenosis is less well tolerated than mitral regurgitation with higher rates of cardiac failure and need for hospitalization. Symptomatic mitral stenosis is an independent predictor of maternal adverse cardiac events, and severe mitral stenosis is an independent risk factor for adverse fetal outcomes like preterm birth and low birth weight. So what this slide means is that mitral stenosis is worse than regurgitation. Symptomatic stenosis is worse than asymptomatic stenosis, and severe mitral stenosis is also associated with fetal complications. So these are points that we need to remember. We need to start with the physiological changes in the cardiovascular system in pregnancies. As is often the case, We may have listened to it any number of times, but I think before we go through cardiac disease in pregnancy, it helps to recapitulate what we already know. The basic changes that happen in pregnancy in the cardiovascular system are increase in the cardiac output, heart rate, stroke volume, and blood volume, and a fall in the peripheral resistance. And all the problems that occur with the cardiac disease in pregnancy occur because of these basic changes. So the stenotic lesions are tolerated very poorly because of the inability to increase the flow through a stenotic valve in the setting of increased intravascular and increased preload. To make it simple, what I'm trying to say is that there is an increase in the cardiac output, there's an increase in the heart rate and blood volume. A lot of blood is being pumped into the heart, and this heart has to pump much more because of increased cardiac output or the need for cardiac output from atrium to the ventricle. Now, there is this stenosis between the left atrium and the left ventricle, and if the blood cannot be pumped from the atrium to ventricle, it's going to cause a problem, and it's going to backflow or cause an increase in the pulmonary pressure. It is going to cause acute pulmonary edema. It's going to cause left ventricular failure. So it's a preload on the heart. That is a problem because of the various changes that took place. So antepartum, what are the changes? As I already said, increase in the blood volume, cardiac output, stroke volume, which increase the preload and cause pulmonary congestion also, supine hypertension, and increase in the heart rate, all of which act in a very similar fashion. Now, during labor, there's tachycardia due to pain and anxiety, which cause again a reduced left ventricular filling, pulmonary congestion, pumping of blood from the uterus, and increase in the cardiac output, again an increase in preload, postpartum shunting of blood from the uterus, and in the puerperium, mobilization of extravascular fluid, all of them increase the preload. So it is preload on the heart, which causes it. Something that the mitral valve is not able to handle and is not able to pass on this blood to the ventricle, and that is where the problem arises. And that is why acute pulmonary edema is a major killer in mitral valve disease. Now, there are classifications that all of us know of. NYHA classification is used for functional grading or the degree of cardiac failure. Please remember that this is for degree of heart failure or the functional status of the heart. All of us know 1, 2, 3, and 4. Class 4 being severely compromised with symptoms at rest and congestive cardiac failure. We have a second classification, which is used for prediction of maternal outcome. This is called the CAR-PREG cardiac disease in pregnancy scoring. CAR-PREG 1 was there earlier, now CAR-PREG 2. It is a very good way of predicting maternal outcome in cardiac lesions in pregnancy. And this takes into account some of the prior cardiac events, some of the factors that are existing in current pregnancy, and also the time in pregnancy at which the assessment is done. Points are given 3, 2, and 1, and a score is calculated, and that gives you the risk of primary cardiac event or a maternal complication or outcome in pregnancy. Now, the third one, which all of us are familiar with, is a WHO risk classification published in 2018. And this basically is something that we need to do for every woman with cardiac lesion pre-pregnancy, assess the risk, and advise her regarding is pregnancy contraindicated? How often should she see the cardiologist? Should we actually advise termination? Should we advise surgery prior to onset of pregnancy? All these are actually decided upon depending on the WHO risk classification. Now, what are the maternal complications that we anticipate in cardiac valve disease? Acute pulmonary edema is the most common and complication, especially in mitral stenosis, and is the one that causes the mortality. You can also have congestive cardiac failure. Arrhythmias are quite common: supraventricular tachycardia, atrial fibrillation, infective endocarditis, and of course, maternal death due to any of the complications. Fetal problems are actually uncommon in rheumatic valve disease. Tight mitral stenosis can actually give rise to preterm labor and fetal growth restriction. Otherwise, in a mild or a moderate kind of valvular disease, you don't really see too many fetal complications. What are the causes of death? I said mortality does occur. Again, to reiterate, acute pulmonary edema, infective endocarditis, congestive cardiac failure, pulmonary hypertension, aortic dissection, and arrhythmias. Now, I will talk a little about acute pulmonary edema because I've been repeatedly saying it's a most common problem or complication, especially with mitral valvular disease in pregnancy. With the changes in normal pregnancy, antenatally at 28 to 30 weeks, there is a peaking of blood volume and cardiac output. In labor, there is pumping of blood from the uterus and a tachycardia associated. And immediate postpartum, shunting of blood from the placental bed and from mobilization of extravascular fluid. All this again increase the preload, and this is when these are the situations when you can have an acute pulmonary edema. Intercurrent events are even more important. Hypertension. Hypertension complicates preeclampsia, complicating pregnancy, anemia in pregnancy, multiple pregnancy, thyrotoxicosis, acute febrile illness, and atrial fibrillation are conditions that can actually precipitate an acute pulmonary edema. So how do we manage an acute pulmonary edema? Of course, everyone knows it is by nursing in the semi-recumbent position, oxygen administration, diuretics, beta blockers if there is atrial fibrillation, morphine to allay anxiety. You could apply tourniquet to the 4 limbs in sequence, and emergency valvotomy if it is an intractable pulmonary edema. A few words about infective endocarditis. We need to understand that it's a rare event in developing countries, even in developed countries, and even in developing countries like ours, it's becoming much less common. Because bacteremia is a prerequisite for infective endocarditis. You need to have circulating bacteria in the blood. And vaginal delivery is associated with very low risk of bacteremia. This is what the research in the last decade has found. And so the risk of adverse reaction to antibiotic far outweigh the benefits of antibiotic in many of these cardiac lesions or situations. Therefore, the American Cardiac Association, American Society of Obs and Gynae, all of them British, all of them together have come up with the recommendation that it is only to be given in high-risk women. So who are these high-risk women? Women with prosthetic valves or prosthetic material used for valve repair, women with prior endocarditis, cyanotic heart disease unrepaired or repaired within 6 months, repaired congenital heart disease with prosthetic material, repaired cardiac disease with residual defects are adjacent to the area of prosthesis. So your mitral valve disease, rheumatic cardiac disease, none of them come under this category. So when indicated in the high-risk women with the indications that I actually mentioned in the previous slide, what is the antibiotic regimen? American College of Obs and Gynae have said it is a single dose. Please remember, we now recommend only a single dose of ampicillin 2 grams or oral amoxicillin 2 grams. And the American Heart Association recommends oral amoxicillin as the first choice or ampicillin 2 grams IV or intramuscular. Of course, if they're allergic to penicillin, there are all kinds of alternatives. If a woman is undergoing a cesarean section, there is a recommendation for standard admission of a single dose of cefazolin 30 minutes before incision in women who are undergoing cesarean section. That antibiotic, the single dose of cefazolin, is sufficient to cover infective endocarditis, and therefore no additional antibiotic is required if a woman is undergoing a cesarean section. So this recommendation that I put up is only for those undergoing vaginal delivery in women who have the indications that I have already mentioned. There are some institutions which add 1 dose of gentamicin to this, and some don't. That was a previous recommendation. Now, actually, that has been removed from the current recommendation. Now, how do we diagnose cardiac disease? It is not very simple in somebody who comes in the pre-pregnant stage. I mean, you might auscultate and find an abnormality, or she may present with symptoms and you may suspect. But because a lot of changes take place in the cardiovascular system in pregnancy, these changes can actually mimic a cardiac disease. That is, many pregnant women are breathless, especially in the third trimester because of the progesterone and what it does for the respiration. Many have pedal edema. There are anatomical changes because the pregnant uterus pushes up the heart and pushes it to their left, and therefore heart is displays upwards and to their left, apex be shifted. Physiological heart sounds can be heard and functional systolic murmurs can be heard. ECG again, because of the anatomical changes, shows left axis deviation. I think somebody hasn't muted. Left axis deviation, and chest X-ray again can show an apparent cardiomegaly. So one need to be aware of all this before you make a diagnosis of cardiac disease. And so look for symptoms and signs which are suggestive of cardiac disease, which are dyspnea on mild activity at rest, paroxysmal nocturnal dyspnea, hemoptysis, and chest pain. Signs like cyanosis, edema up to knees, systolic murmurs, murmurs associated with trill, diastolic murmurs. Whenever you hear a diastolic murmur, it is pathological. Systolic murmur can be physiological or pathological, but diastolic murmurs are always pathological. Split second heart sound, etc., etc. I think many are aware of these. Of course, once you've suspected a cardiac disease because of the symptoms and signs, you will evaluate with an ECG, which will show you the classic findings in whatever be the valvular lesion. Chest X-ray might give you an idea of the cardiomegaly. Echocardiography is something that everyone does now, and I think that is the cornerstone of diagnosis. It will only tell you which valvular disease it is, and will also tell you the diameter of the valve so that you can assess the severity and assess the need for surgery. Can they go through pregnancy without surgical intervention? Or if it is severe, what problems are they going to face? Cardiac catheterization may be used in selected cases where accurate diagnosis of the lesion is actually required. Now, preconceptional management is extremely important. I do know that, and all of us admit that a certain percentage of these lesions are actually diagnosed only in pregnancy, even now. But if you do see women preconceptionally, I think and you know that they have got a cardiac lesion, many of them come to you with the history or with the diagnosis. What are the things that you really need to find out? Because this is a period, preconceptionally is a time where you can intervene and do something and improve or definitely alter the prognosis in these women. So history of effort tolerance, history of cardiac surgery, you need to evaluate the medications. How do we manage? If it is anticoagulant, what do you do? Antihypertensive, are they safe, unsafe? Complications in previous pregnancy. If they had a worsening of functional class, it means it's going to worsen now, and therefore you need to intervene surgically. History of pulmonary edema, etc. Evaluation, you need to look at the type of lesion, severity of the lesion by the echocardiography, functional classification, WHO risk stratification. I already mentioned it has to be done pre-pregnancy, and presence of pulmonary hypertension. Now, having done all this, you need to counsel the woman and explain to her what are the risks involved for the mother and fetus, and does she require a surgical intervention prior to her getting pregnant? And are there contraindication, absolute contraindication, primary pulmonary hypertension, Marfan syndrome? Does she have contraindication to pregnancy? You need to look at those. And surgical correction should be advised in moderate to severe mitral or aortic valve lesions, tight mitral stenosis, cardiac failure or an NYHA class 3 or 4 in previous pregnancy. You could do a balloon valvotomy for stenosis or valve repair or replacement for regurgitation, keeping in mind that they will be on anticoagulation, and you have to manage those as well. When do you advise termination of pregnancy? When she comes to you early, if the maternal risk is very high, like the WHO class 4, the NYHA class 3 or 4 at presentation, severe stenosis, aortic or mitral, severe left ventricular dysfunction, and pulmonary hypertension. Mortality is so high that termination is better in these women, and they can always conceive after you terminate. Now, the woman has come to you pregnant. What do? We need to manage them in a tertiary center. A multidisciplinary team should be available, consisting of the cardiologist, obstetrician, neonatologist, and anesthetist. Actually, the WHO classification and stratification tells you how often they should visit the cardiologist. Even that recommendation is actually given there. A thorough evaluation at first visit is mandatory because you need to establish an accurate diagnosis, NYHA classification, CARPRED risk stratification, WHO risk categorization, and maternal and fetal risk factors. All these should be done, documented in the antenatal folder, so that we plan what are we going to do with her now. Are we going to terminate? Are we going to continue pregnancy? Are we going to see her antenatally? Are we going to admit her? What are the risks, etc., etc. So you need to counsel regarding termination of pregnancy, cardiac surgery, which may be required in pregnancy. Tell her what are the lifestyle, physical activity as tolerated. Prompt reporting of respiratory infections, mainly because they can precipitate cardiac pulmonary edema, symptoms of pulmonary edema and congestive failure. She needs to know that these are the symptoms. You have to monitor hemoglobin, blood pressure. As I said, anemia and hypertension are one of major, in addition to respiratory infection, are major causes of pulmonary edema. Fetal growth must be monitored. If it is a type stenosis, maternal complications should be looked for. Prompt treatment of anemia, hypertension, absolutely mandatory. Recheck hemoglobin in the second trimester, third trimester. You must monitor blood pressure very closely. Look for respiratory infection, and asymptomatic bacteriuria must be diagnosed and treated. If the woman is in NYHA class 1 and 2, manage as outpatient, re-evaluate every visit and at 28 to 32 weeks, because cardiac output and blood volume peak at that time. And so those who are in class 1 and 2 can easily worsen. And if that happens, you need to hospitalize and manage accordingly. If they are class 3 and 4 from the beginning, you need to hospitalize them. If they have not undergone surgery, surgical intervention or termination, and they decided to continue pregnancy, you need to keep them in hospital. What has really changed the management, in medical management, is the introduction of beta blockers. Earlier, we only gave them digoxin and diuretics. That was 20 years ago. But now, beta blockers have really become the cornerstone of management, because they reduce heart rate and thereby mitral gradient, reduce New York Heart Association and class symptoms in about 90% of women. It allows full-term delivery and no recurrent cardiac failure. Selective beta-1 blockers like metoprolol and carvedilol are that which are used in pregnancy. They've actually revolutionized the management. Of course, if they have atrial fibrillation or arrhythmias, verapamil or any other drug which is indicated should be used at that time. So just to summarize the antenatal management, cardiac disease, accurate diagnosis, NYHA, Capra classification, and WHO risk scoring is important. If pregnancy is contraindicated, advise termination. Otherwise, review medications and counsel. Class 1 and 2, routine antenatal care as outpatient. Review class NYHA at 28 to 30 and deliver at term. If they are class 3 and 4, in the first trimester, advise termination. In the second and third trimester, admit and treat cardiac failure and pulmonary edema and deliver at term. How about cardiac surgery in pregnancy? We used to do quite a few. Now we don't see so much rheumatic cardiac disease. Severe mitral or aortic stenosis and recurrent pulmonary edema not responding to treatment are definite indications for a balloon valvotomy. Cardiac valve replacement, actually a much more major procedure, is not undertaken that easily, but a balloon valvotomy actually or valvotomy in other ways is a very well accepted management. How do we manage intrapartum? Valvular disease is not an indication for elective cesarean section. That I think all of us must understand and all of us know. We must also remember that labor is equivalent to moderate exercise. As in, there is tachycardia in labor, there's increase in the cardiac output, there's increase in venous output. Because of this, pulmonary edema, acute pulmonary edema and cardiac failure are quite common. So keeping in mind these problems, you need to give her adequate analgesia or even an epidural, which is recommended, so that the tachycardia will come down. You need to closely monitor pulse, blood pressure, and keep auscultating the lungs to see if she's going into pulmonary edema. Antibiotics, I've already discussed, use it only if indicated. Though there is some controversy about the forceps or vacuum should be used in second stage, most people believe that in order to prevent a Valsalva maneuver, especially in those with moderate to severe disease, outlet forceps or vacuum will certainly save a few pushing efforts and contractions for the woman. Avoid ergometry, because already there is shunting of blood from the uterus into the vascular system and into the heart. And if ergometrin is administered, that will precipitate it further. And again, it can cause an increase in the preload on the heart. postpartum, close monitoring since decompensation occur. Remember, as I repeatedly said, because immediate postpartum, there is shunting of blood, and in the puerperium much later, there is mobilization of extravascular fluid, which is going to go back into the system, and therefore, pulmonary edema is very common. So close monitoring is very essential. Thromboembolism can occur. You should watch out for it. You need to reassess cardiac status at 6 weeks and then advise regarding cardiac surgery and future pregnancies. Advice regarding contraception, of course, all the progesterone implants and intrauterine systems and are all quite safe. Copper intrauterine device is not contraindicated anymore if the woman has completed family. If she is NYHA grade 1 or 2, tubectomy is quite all right. She will tolerate anesthesia. You could coax the husband to have a vasectomy, of course. Thank you very much for your patient listening and your cooperation. Thank you. Thank you.
Thank you so much, ma'am. You know, I don't know how much of Hindi you know, but there's a saying, Gagar mein sagar. You know, to have the sea in a pot. So that is how it has been, and you've made it sound very easy. Alka ma'am, would you like to say something?
Yes, I'm so sorry because I have some emergency cesarean section what I have to do. So I was just examining the patient, madam. Lakshmi Seshadri, madam, your presentation was so informative, and it has covered all the aspects of cardiac disease, which is rather difficult to treat. And previously we used to have many rheumatic heart disease when I was doing my PG 40 years back. But nowadays, because of the good antibiotics, now rheumatic heart disease, their number is reduced. But still, the patient, how to manage them is still very difficult. And you have made it so easy, and you have given all the points on every aspect, like antibiotic, only amoxicillin has to be given 2 gram, and in surgery also. Your presentation is, madam, absolutely fabulous. Thank you, madam.
Thank you. Thank you very much. Thanks for the opportunity. And Dr. Asha, I will be in touch with you. Thank you.
Yes, ma'am.
Thank
you. Thank you so much, ma'am. It's my honor. Now, Dr. Abha Singh has joined us. Singh, ma'am, we had already introduced you. So if you would say a few words. You've been listening to the program. Dr. Abha Singh, ma'am.
Yeah, thank you. Thank you, Dr. Asha. Thank you, Dr. Asha. I am traveling in the metro, so there may be a lot of noise. But yes, it's a very important topic. Cardiac disease and pregnancy was very common in our PG times and in our earlier days of consultancy also. But now it has reduced. And the only thing is that you have to pick up the cardiac disease during pregnancy. And in antenatal patient, it's very important to first auscultate the heart, which the younger generation, they don't have the habit of auscultating the heart and lungs. So that has to be mandatory. And you will be able to pick up the heart disease. It is not really very difficult to pick up the heart disease. And then you can start the management at early stage so that patient does not land up pulmonary edema when she visits you. And if she comes at 28 weeks, again, there are more chances of having pulmonary edema. So you have to grade the patient which in HY classification she stands. And Dr. Seshadri is very right told about the CARPEG study also. And Dr. Seshadri has covered all the points which you should know in a patient of heart disease. So thank you. I'll not take much time because I'm traveling and you may not be able to hear me properly. So thank you, Dr. Asha, and continue such activities in future also.
Thank you so much. Thank you. Really great of you to log in from the metro. I'm very grateful, ma'am. So, Sujayasri, over to you.
Yes, so moving on to the second session. The chairperson is Dr. Shabana Sultan, ma'am. She has presented many papers in the national conferences. She's a member of an esteemed team of PPH Bundle along with Sevagram. She's been the past joint secretary, past treasurer, and also the executive member of MP ISAR chapter. She's done various international projects along with, I think, in association with the Harvard University. Her special interests are gynec oncology and high-risk pregnancy. She's also a master trainer of cervical screening program. It's a great honor to have you with us, ma'am. I think Dr. Shabna ma'am has not logged in due to some personal
Her
reasons.
son is hospitalized, so she's not been able to join in. Dr. Ruchi ma'am, would you do the honors, please?
Yeah.
Yes, ma'am. It's a pleasure to be here. Welcome, Dr. Reena Wani. She's professor, she's MD FRCOG, FICOG, FC, PS, DFP, DGO, FICOG, professor and head of Department OBGY at HBT Medical College and Dr. R.N. Cooper Hospital, Mumbai. She's president, Mumbai Breastfeeding Promotion Committee. She was the president from 2019 to 2022. She was the program committee chair, Association of Medical Consultants, 22-23 and 24-25. She is member FOXI GCPR for COVID guidance and vaccination in the year 20 to 21. Core committee FOXI Violence Against Women Cell, 2015 to 21. Chairperson of the FOXI Perinatology Committee, 2015 to 2017. She is an ICOG Governing Council member. She was from 21 to 23, more than 50 plus chapters in FOXI and other books, and over 75 publications in journals. What a great achievement, ma'am. Editor and co-editor of 15 books, author of 2 textbooks. She has gold medals, distinctions, prizes, awards, Lifetime Achievement Award, Best Teacher Award, Marks Personality of the Year. Welcome, ma'am. And she's also an examiner and referee for the MRCOG exam. Welcome, ma'am. We are waiting to hear you.
Thank you very much, Dr. Asha Jain and the whole team for this kind invitation. And I think Dr. Seshadri has given a wonderful presentation. And apologies, I'm a little under the weather, so I have a bad throat, but I will do my best to cover the topics. Can I share my screen now?
Yes, ma'am, you can share.
Yes. Yes. And, congenital heart disease in pregnancy with a focus on obstetric management is what was my brief for the day. And if you look at the bottom of the screen, Vidya no Rupvi Muktaye, through knowledge we shall conquer disease, was the motto of Nair, where I spent 21 years as a teacher. And now I am at Cooper Hospital with HBT Medical College, which says Arogyam Dhana Sampada. That is, health is truly the greatest wealth. So this is the entire gamut. In brief, I will touch upon in the next 15 to 20 minutes, with the focus on patients with congenital heart disease. Dr. Seshadri has also already mentioned that rheumatic heart disease is most common, but we are seeing advancements in medical and surgical management. So congenital heart disease patients are now reaching childbearing age successfully. And this is why we need to be focused on this. We are now at the cusp of being a developed country. India is no longer really a developing nation, and we are doing better with management of congenital heart disease patients. And you will find more patients coming to you. And you can see the ratio between RHD to congenital heart disease has changed over the past 2 decades. In fact, reaching about 3:1 or even 1:1 in developed countries. So friends, we've already talked about the physiological changes, but the 2 times, the peak output range, which reaches in second trimester and then 32 weeks, and changes to the baseline taking time, these are the danger periods, particularly when you know there is a patient of congenital heart disease who has had a problem, and after delivery, the autotransfusion and other problems. So we have to be vigilant. There have been many causes for the changes in the hyperdynamic circulation of pregnancy, which Dr. Seshadri has already covered, and these will aggravate changes in a patient who is not compensated. and certain things which may mimic or mask cardiac disease. But what is important is sometimes some congenital heart disease, for example, a mitral valve prolapse or something which is not manifested so far, may manifest for the first time in pregnancy because of the changes. Sometimes we get a clear-cut history of a previous cardiac surgery or an event, which makes us know what kind of a case she is. So we have to be aware of the symptoms and the signs which can help us pick up, because missing the diagnosis is one of the reasons why sometimes we tend to have a bad outcome or lose a patient. These are very important Burwell-Metcalf criteria, which will tell you that the murmur you're hearing is truly pathological, or it's an organic murmur, not just a functional murmur. Particularly in congenital heart disease, presence of resting dyspnea, PND, a diastolic murmur, unequal enlargement of heart chambers, and arrhythmias make you vigilant. Sudden death and maternal mortality is something which really scares us and is something which can come up in any of the cardiac patients. There are risks not only to the mom, but also to the fetus of prematurity, low birth weight, and a recurrence of the congenital heart disease to the rate of 2 to 5% based on what was the type or the etiology. So as far as congenital heart disease, there is a classification of mild, moderate, and severe based on which the outcome of pregnancy can get affected. Simple things like an atrial septal defect may not really have an adverse outcome. VSD is one of the commonest, which may not have a problem, but may manifest due to the change of the pregnancy. But conditions like tetralogy of Fallot or Epstein's anomaly, previously you would not get them reaching childbearing age group, but it might happen now. But pulmonary hypertension and Fontan circulation can be really severe. So preconceptionally, friends, when you know it's a patient of congenital heart disease, we need to talk to them, assess the maternal risk using the Cartwright scoring, and then discuss risks and potential complications, optimize the medical management before pregnancy, and consider genetic counseling before she decides to get pregnant. Unfortunately, a lot of patients come too late. And Madam has already mentioned the Cartwright score, but I'll tell you a little bit in detail. The components are C for cardiac dysfunction, A for arrhythmias, R for respiratory diseases, P for previous cardiac events, R for revascularization from previous cardiac surgery or intervention, E for other risk factors like diabetes, hypertension, and smoking, and G for gestational hypertension. And based on the points, you will find that the chance of cardiac complication as calculated as a risk will vary from 5% to 75%. This can make a huge difference between life and death. And this is the mathematical model from the study based on the 10 predictors as shown in the box. Well, sometimes, man proposes and God disposes. And sometimes some patient which you think may not make it through the pregnancy does well, whereas another one who you thought would do okay would have a sudden cardiac demise. So the 3 C's, counseling, choice, and good care are important for a good outcome. This is just a summary of the classification with the advantages and limitations which could be there, and the groups which I've already mentioned. So importantly, what are the WHO class 4 risks? Somebody with a Marfan syndrome, aortic root dilated more than 45, previous cardiomyopathy, and pulmonary arterial hypertension of any cause. So with the respectful maternity care, we can help these ladies decide whether they want to take these risks of heart failure, arrhythmias, thromboembolic phenomenon and stroke, or endocarditis, and the risks to the fetus in their chase for having a good outcome in pregnancy. The NYHA classification applies to all types of heart disease. It's already been covered, but you need to know what class your patient belongs to when you are planning for the pregnancy and the management. This, in a nutshell, highlights your antenatal management. Friends, the word here is multidisciplinary team. No man is an island. You as an obstetrician are primarily responsible for the outcome, but taking inputs from the cardiologist and also anesthesiologist, because pain is a trigger factor for tachycardia, which can worsen outcomes. And also, in case they do require a C-section, what is the choice of anesthesia? So evaluation early rather than when she's gone into labor is important. Regular monitoring, adjusting the medication as needed, and having a plan for delivery. Would we be able to do a vaginal, or is an elective cesarean the better choice? A fetal echocardiogram is also important. And now that our limit for termination of pregnancy has shifted to 24 weeks, I'd like to just say that you may pick up an anomaly pretty late, but the risks of termination of a cardiac disease case at 22 to 24 weeks would be close to what it is at term. So these are choices which we have to make, keeping the patient and her family in the loop. The special investigations like an ECG is very cost effective, but certain changes may mimic heart disease and vice versa, you may not be able to pick up. So echocardiogram is the best method to detect the structural abnormalities, severity of the lesion, assess the pulmonary hypertension, and the function. There's a Wilkins score. This is more important, of course, for the rheumatic heart disease, so I won't go into the detail. X-ray chest, we tend to avoid as obstetricians. But please remember, with an abdominal shield, it should be done as required if we need it for the management. The stress test is something which we usually avoid in pregnancy. And this would not be applicable to most congenital heart diseases, but MRI has a special place in certain cases where you want to quantify the changes of pregnancy in the patient when you are planning the delivery. Factors like infections, anemia, PIH, hyperthyroidism, use of tocolytics or can all trigger failure and adverse events. So we need to avoid this. And ACE inhibitors and warfarin. A word about warfarin embryopathy. We've been all taught about it. Often the patients come to us when they have already crossed the first trimester. Then is it justified to change? Because even with use of warfarin, it is only about a 35% risk. 65% of them will be fine. So this is a fine line you have to walk to decide what anticoagulants and of course, how to go forward. So frequency of ANC visits don't really change. In fact, the minimum 4 visits as recommended by WHO may be too less, but whatever you're doing for your patients is what you should continue. But remember, tocolytics are contraindicated. Indomethacin may be used. Fetal 2D echo is recommended for in the second trimester. And valvuloplasty or surgery may be the last resort if the person has worsened in pregnancy. But usually it is not done electively at this point. Vaginal birth is always safer for the mother unless there is an obstetric indication for cesarean. And induction, if you want to use oxytocin, it should be with a concentrated drip with fluid restriction. Deferred amniotomy, ARM, we usually do, but it can worsen the risk of chorioamnionitis. And PGE2 gel can be a vasodilator and may increase the cardiac output. So be vigilant. And of course, misoprostol is not recommended in heart disease unless you're using it for PPH and where there is no choice. But these are drugs you have to use with caution. Intrapartum monitoring, hemodynamic monitoring is very important. Epidural is one of the methods of choice because it reduces the pain, reduces tachycardia, and helps in the delivery process. And if you do need to rush for cesarean, the patient is already having the catheter in place. Place of induction, and this I have already discussed. These are certain references from British Journal which talked that induction of labor is relatively safe in cardiac disease and there is no difference in LSCS. Management, studies have suggested vaginal is preferred to cesarean except in certain conditions, as listed in the slide, which I have already mentioned to you earlier. Some patients may be better off with the elective cesarean if you want better control of ventilation, fluids, and cardiac stress, particularly if they are very anxious or are at a poor risk for emergency GA. Supine versus lateral decubitus position is something which you have to think about based on the type of cardiac lesion. And here again, positioning is something which you can take a multidisciplinary approach and decide, but a semi-recumbent position is usually the safest in labor. And avoid tachycardia and pain. And previous history is something which will warn you of what can go wrong. The general management, of course, is going to be the same, but continuous ECG is required in congenital heart disease patients. This humble pulse oximetry, which became so popular in COVID, is something which we should have in all our labor rooms, and that's what's going to help. And cutting short the second stage of labor with a prophylactic, well-applied forceps would be helpful. Vacuum requires some amount of exertion by the mother, but if you feel your forceps cannot be applied comfortably, definitely go for that. Avoid oxytocin bolus. Rectal misoprostol, yes, if it's required, life-saving. Avoid methogen and prostudin. Postpartum management, of course, vigilance for complications, gradual mobilization. Breastfeeding should be encouraged, and definitely follow-up and observation for a longer time. Nowadays, with the wards being overcrowded, we tend to discharge patients by the second, third day. But heart disease patients, definitely at least a week. Most of the older books recommend 10 days of observation. This is a very critical time because in general, it's a 6 times higher risk of thrombosis in postpartum women and more so in women of heart disease. The anticoagulants can be continued. In fact, if she's on heparin, you stop it in the time around labor and restart it within 12 hours. Most women can breastfeed. And of course, they need to be reassessed because at 4 to 6 weeks, the hemodynamic changes return to the non-pregnant state. This is the mortality-based classification, which is going to tell you. But friends, the statistics are something which are there for us to see, but how we counsel the patient and what she wants is what finally determines the outcome. Specific considerations where you should say a no to pregnancy are listed in this slide, which I've already talked about. So friends, this is in a nutshell, what are the recommendations with level of guidance for the use of anticoagulants in pregnancy. And this is also what you would do for specific syndromes and aortic diseases. I know we are running late, so Dr. Asha is giving me signs. So I will just briefly go through the last few slides.
Oh, I'm not giving you signs, Dr.
Oh, I thought you were...
No, no.
So,
I was
right.
just taking a screenshot of what you have displayed because it's so small that we would need it later.
In fact, I'm more than happy if you want to share the PPT with everyone. I believe that knowledge is for sharing. I have no objection. You can share the PPT with whoever is interested. I've already sent it to you on personal message.
Thank you.
There are causes of maternal deaths, which are listed in this slide, but aortic dissection and primary pulmonary hypertension are very important causes. Myocardial infarction is not usually in our cases of congenital heart disease, but because of changes in our lifestyle, we are finding we are getting patients with myocardial issues also in pregnancy. Coming to contraception, you know, preventing, here I'd just like to end with a little story about one patient who came to me when I was at Nair. She was previous to LSCS with breech, with cardiac disease. And she said, doctor, मेरे second cesarean पे मैंने डॉक्टर को बोला था बच्चा बंद करने का ऑपरेशन करो. And the doctors didn't do it for whatever reason. The husband did not get a vasectomy, and here she was pregnant again with breech, and she actually collapsed on the labor table. And we were taking her up for cesarean because she went into preterm labor. So these are preventable things. So contraception properly used and applied, although male sterilization has the least risk for the woman, Again, we have to think of it from social perspective, that if she has a lesion which is going to lead to her death, the partner has the choice of a second marriage. So we have to look at it from a holistic perspective. Of course, barriers are the best, but they have high failure rates. IUCDs, if put in properly, I feel are a very good method. And the Planned Parenthood Federation has said that with proper cover, the PP-IUCD also we can use. And I am using it in patients with heart disease. Proper infective endocarditis prophylaxis in high-risk settings is required, but a clean-cut delivery and other things may not require in the foreign countries. But in our setup, I would say I would not err on the side of not giving it. It is much better to use the antibiotics. These are the categories which they say are negligible risk, but including a surgically corrected ASD, VSD, and a patent ductus arteriosus. But again, friends, I would say it is better to give than not give in our setup. Moderate risk are these in which unrepaired ASD, VSD, PDA are the congenital heart diseases, and mitral valve prolapse, which is often congenital when there is associated regurgitation. They also require, and vancomycin is a good option when there is a penicillin allergy. Please remember that the ampicillin, amoxicillin are very good for infective endocarditis prophylaxis. Although we tend to go for the other antibiotics, I feel it is better to reserve the higher antibiotics for situations when you are going to have a worsening of the patient. Otherwise, you will end up having nothing to use when you need a higher antibiotic. These are other specific considerations. I will just briefly mention in aortic stenosis, if the valve area is less than 1 centimeter squared, this is a very high risk for failure, and symptoms like dyspnea, angina pectoris, or syncope may be there in these cases. But congenital bicuspid valve is one of the most common causes, not acquired. Cornerstone for management is bed rest. Here is one of the cases where GA is a must if you need to give it, not epidural or spinal, because the cardiac output is fixed. Unlike what I had said earlier, for most of the other patients, the spinal or epidural is a good choice. In aortic regurgitation, maybe due to a congenital bicuspid valve or other causes, but it is usually pretty well tolerated with medical line of therapy. Please remember, when we are giving anticoagulants, the whole goal is to keep the INR between 2 to 3, not normal. Sometimes the postgraduates themselves are confused that, Madam, INR is normal. I said, but that's not good. Our anticoagulation is not working and has to be dose adjusted throughout pregnancy. And the advantage of low molecular weight heparin, as we all know, can be discontinued, and within 12 hours, you'll be able to reverse it. I had talked about warfarin embryopathy, and the typical nasal hypoplasia, hypertelorism, prominence of frontal bones may be there. But friends, again, if she has come to you beyond organogenesis, I often just continue the warfarin and then switch to the low molecular weight heparin closer to the term, because then it's difficult when you have to stop warfarin. It takes a while for the effect to wear off, almost a week. Look for arrhythmias, particularly premature atrial and ventricular complexes, and SVTs. SVT can be terminated by, what you call a carotid massage, as simple as that. It can be taught to the patient. And intravenous drugs like verapamil or diltiazem. Direct current cardioversion can also be used in pregnancy. And mainly, those with complex congenital heart disease just require closer monitoring. With modern technology and facilities, these women should not be denied the opportunity to become a mother. And the risk to the offspring is actually not a huge increase. 1% in the general population just goes up to 3 to 5%. So we can reassure them that they'll be okay. A little word about Eisenmenger syndrome, which is when the shunt has changed the direction and it's acquired elevation. And once Eisenmengerization of a septal defect occurs, ideally this patient should not become pregnant, because here is a patient with a very high risk of mortality. So in fact, if they have a shunt lesion and they are not yet having a reversal of shunt, These are the patients who should finish their childbearing early rather than late. Primary pulmonary hypertension, not very common, but has a very high maternal mortality. And these are also women who should not get pregnant. I won't talk about coronary artery disease. It is not congenital, but we have to be aware that we need to differentiate this. Coarctation of the aorta, not very common, but can be associated with aortic dissection and rupture. Marfan syndrome is a connective tissue disorder inherited as autosomal dominant trait. And this is something where if the dilatation is more than 50, surgery should be done, ideally before she gets pregnant. And here is where beta blockers are a mainstay of treatment. As Amartya Sen has said, amongst the most important freedoms we can have is freedom from avoidable ill health and escapable mortality. Friends, correct management of heart disease is going to help, and with appropriate counseling, contraception, family planning advice, referral in time to a higher center, and concentrated team efforts, we can definitely save these women's lives and have a good outcome for both. Early detection, appropriate referral, close collaboration with our cardiologist friends, and we are going to discuss cases in the later session, I'm sure we'll get a better outcome. Congenital heart disease requires special care. Preconceptional counseling is very important, and with understanding the risks, we can have good outcome for mother and fetus. These are some of my references, and I'll be more than happy to share the PowerPoint. And as our aim in Foxy is centered to the mother, and this year we are talking about coordinate, communicate in the community. Let's aim on keeping safety first for the Indian women and for their babies. Thank you very much for the invitation and the patient hearing.
Thank you so much, Dr. Reena. Ruchi ma'am, over to you.
Dr. Reena Wani, again, I'll say Sagar mein Gagar, Gagar mein Sagar. It was all so concise. You have touched on all the different cardiac problems that we can face in pregnancy. And yes, it is a multidisciplinary approach. We need to be in touch with a cardiologist and a neonatologist and an obstetrician and an anesthetist. It's not a one-man job when we are dealing with a cardiac patient. And thankfully enough, with all the advances in science and technology, we are able to save a lot of mothers. And as you rightly said, we cannot deny her the right of motherhood. Of course, some contraindications, absolute contraindications are there. We have to follow them to save the life of a mother. We have to be a little firm on those grounds. But rest of the women, I think with good care, we can see them through becoming a mother. Thank you very much, Dr. Reena. That was such a pleasure.
Lakshmi ma'am, would you like to say something?
Yeah, yes, I was really listening to every word of what Dr. Reena was saying. It's not a very easy topic. Rheumatic cardiac disease is easier to deal with because we've seen them for decades, day in and day out. Congenital cardiac disease, each congenital anomaly is different. Some have, when they have a problem of left to right shunt, right to left shunt, reversals. Some have stenosis and multiple level blocks and abnormalities. And therefore, you need really a very close involvement with the cardiologist. The complications in pregnancy are different in some, as she mentioned, pregnancy is contraindicated, and managing congenital abnormalities of the heart and pregnancy along with it is quite a challenge. I think she really highlighted each one of those conditions very well and made it quite clear. And I congratulate you on that very nice presentation, Dr. Reena. Yes.
Thank you, madam. Following in your footsteps, it was easier. You had given a wonderful talk before that. Sorry, I was not able to participate at that time because of some personal issue. Thank you very much for the invitation and being on the same platform with all wonderful speakers like you.
Ma'am, can I ask a question?
Sure, yes.
Hi, I'm Dr. Veronica Yuel from Raipur, Chhattisgarh. Ma'am, everything about pregnancy and all we have discussed. I have one question which we have very frequently faced here is, some of these patients, when they come in early first trimester and they want a termination of pregnancy, how safe is medical abortion to be given to them? Can we use it or we should not be using it? Sometimes they come very early, 5 weeks, the sac is very small.
So actually, Veronica, this is actually a very good question because misoprostol by itself, one of the problems associated with misoprostol was the effect on the heart. And
Yes, I
here
read
when you
I
use,
saw it in your lecture. That is why I
yes,
asked this.
which is why usually we prefer not to give medical method of abortion in these patients. And to be honest, as I have already said, with heart disease compared to the other things, I usually counsel them that, hey, if you're pregnant now, as you grow older, your heart disease is only going to worsen. So if you want to have a child, this is the right time. Let's finish it off. We will help you along the way. And we help them to make that choice. But if we are doing a procedure, I usually do not go for medical method in these because it's administered at home. There is no monitoring. And then if things go wrong, it's a problem. So unless the patient is insistent with a high risk signature, then only I would give it. But otherwise, I would counsel them to come. I don't know what Dr. Seshadri, madam, what do you feel?
If they are well controlled, they are NYHA class 1 or 2. And I mean, we generally don't advise termination, but we are doing that. I would hospitalize them and give them. Because even for induction of labor, misoprostol, initially there was a lot of excitement about it being contraindicated, but now we feel that the risk was actually, what shall I say, much less than what it was thought to be. So if they are well compensated, I would admit and administer medical. Mifepristone is pretty safe, and it's only when you're putting in the misoprostol that you need to keep them for 24 to 48 hours. So I'm okay with it. If not, I will go in for a vacuum evacuation.
Yes.
Yes.
Actually, madam, what tends to happen is that when you admit for the medical, it becomes a prolonged procedure. So a lot of patients are not willing to stay in the hospital for longer time. But what madam is saying is right, that basically the issue is they should be under supervision,
Supervision.
whatever is
Yes.
being done.
Right. Thank you, ma'am.
Anybody has any other question? Anybody? Dr. Reena and Dr. Lakshmi, you've made my day. You know, I've really learned so much. I had read for the panel, but things are much clearer in my head now. So thank you so much. And
Can I ask a question, Dr. Asha?
please, ma'am, go ahead.
I would like to know if warfarin, when would be like, if the patient is using it, so at the time of delivery, would we be liking to stop it and when?
So this, I think I had mentioned in my talk that warfarin is something which is not recommended beyond 34 to 36 weeks. You should switch to unfractionated or low molecular weight heparin because they can go into preterm labor. And if they go into labor, the window of opportunity to stop heparin and ensure that she doesn't have a bleeding is going to be very, very difficult to handle. Whereas with the heparin, you have within 12 hours and you can always give the fresh frozen plasma if you don't have anything else and it will take care. So I would not recommend warfarin to be continued in the third trimester. Most of the guidelines.
Yeah. After
Can I add a
36
point?
weeks, we continue.
Yes,
We
Dr.
have a
Deebanshu.
cardiologist with us. Dr.
Yes, please.
Deebanshu Gupta is there.
Yes, please tell us.
Yeah. Hi, good evening, everyone. So I think the guidelines very clearly state about how to use warfarin and all the oral anticoagulation during pregnancy. So if a patient of known valvular heart disease, when he comes to you and he or she is pregnant, so if the dose of warfarin is less than 5 mg per day and the dose of acetrom is less than 2 mg per day, it is a class 2A indication to continue with warfarin or acetrom in the first trimester. And then in the second trimester, if the patient is tolerating warfarin and acetrom, her INR levels are maintained, you can either continue throughout with the acetrom up till the 36 weeks, the oral anticoagulation, and then at 36 weeks, you switch over to unfractionated heparin. And 6 hours before the delivery, 4 to 6 hours before the delivery, you have to stop unfractionated heparin and then continue post-delivery as per the guidelines. And you have to make the patient understand that no anticoagulation regimen is safe for both the mother and the fetus. There are some risks involved with every regimen, whether it is to give low molecular weight heparin or clexane throughout the pregnancy, whether it is to switch over from clexane in the first trimester to warfarin in the second trimester, then again switch over to unfractionated heparin. But all these risk benefits have to be weighed against each other whenever we are prescribing such a regimen to the patients.
Yes, thank you, Dr. Deebanshu. I think he has answered it very clearly.
Thank you.
Okay, thank you very much.
So now we would like to start the panel. Lakshmi ma'am, are you going to be there or you would leave?
I'm expecting some guests. If they come, I might have to leave. Till then, I will be around.
Okay, Reena ma'am. So we have big people who are listening in, and what the panel that I've made is basically to revise what we have learned today. So Shri Ganeshaya Namah, that's a tribute to my guru. Big undertakings begin in a small way. So let's be happy and learn some more. I would like to introduce my faculty today. We have Dr. Deebanshu Gupta, who's an MD Medicine and DM Cardiology from NHL Medical College and VS Hospital, Ahmedabad. He's also DNB Cardiology, consultant cardiologist at Sarvodaya Hospital, Jalandhar. He has scored first rank in DM Cardiology, has research work on distal radial access in A.V. Gandhi Sky Award for Excellence in Cardiology, part of sub-investigator in Odyssey East trial, over 15 publications and chapters in various books, and he's passionate about preventive cardiology and distal transradial interventions. I thank you, Ruche ma'am, for getting him for me.
Thank you, ma'am. Pleasure being here.
Then we have Ruche ma'am. All our Searchlite viewers know her already. She's a consultant and director, Bhargava Advanced Gynec Surgery Cancer Center. She's past secretary, Foxy Jalandhar, chairperson academics, Foxy Jalandhar, patron PCOS Society, and faculty at national and international conferences, which actually says very little about Ruche ma'am, who is passionate about ethical, correct practice in obstetrics and gynecology. So welcome, Ruche ma'am. I'm really honored and happy to have you with me.
Thank you.
I have my next three panelists are from Bhopal, and I thank Dr. Monica Gupta for helping me get these panelists, because cardiac disease is such a topic people are not ready to join. And I thank myself for Veronica. She works in an institute. Her husband is an anesthetist, and she works in an institute that takes high-risk patients. So I'm glad to have some great panelists. Dr. Nandini Singh Bhati, Assistant Professor, Gandhi Medical College, Bhopal, various publications in national and international journals, has presented papers and posters, special interest in reproductive medicine and gynec oncology, and got the first prize in oral paper in VPCon at Bhopal.
Thank you,
Dr.
ma'am.
Shikha Para, welcome, Dr. Nandini. If you would all have your video on, it would be good. Can't see everyone.
Yes, ma'am.
Dr. Shikha Para, Assistant Professor, Department of Gynae, GMC, Bhopal. She has a teaching experience of 3 years, trained in high-risk obstetrics, infertility, antenatal and gynec ultrasound, and
Thank you, ma'am.
preventive oncology, has publications and many awards. Welcome, Dr. Shikha. Then we have
Thank you,
Dr.
ma'am. Thank
Varsha
you, ma'am.
Rani. She's an MBBS 2007 from MGM Indore, MS Gynae from Jabalpur, and F Mass from World Laparoscopy Hospital. Welcome, Dr. Varsha. And Veronica, where's your CV? Dr. Veronica Yuel is a trained reproductive medicine specialist. She has her own laparoscopy center and IVF center. She's an IVF. I think she's the first reproductive specialist of Chhattisgarh. And she's working in NHMMI hospital, has many presentations, papers, and keeps on writing chapters and books. Welcome, Veronica. Really happy to have you.
Thank you, ma'am.
So now we proceed to the questions proper. This is just to remind myself of all that we can ask. So what is the maternal mortality? This is a recap of what Reena ma'am has just said. What is the maternal mortality due to cardiac disease in pregnancy? Means there are different diseases, some with less than 1%, some with 5 to 15%, and some with 25 to 50, where we contraindicate pregnancy. So,
May I take this question?
yeah, go ahead.
Actually, maternal mortality in cardiac diseases entirely depends on the WHO classification, which has been already talked about in both the sessions.
Yes.
Beginning with the first classification, WHO class 1, where it is all about the pulmonary stenosis, PDA, the maternal mortality is very less, that is less than 1%, and it is a mild of morbidity. When we move on to second class of WHO, where it talks about the congenital heart diseases, which are uncorrected, that is ASD and VSD, there the maternal mortality rises to 5 to 15%. And when we go to class 3, it rises again to 50%, and the class 4 is totally contraindicated, the pregnancy becomes contraindicated.
Can I add to that, Dr. Asha?
Yes, please, ma'am.
If we put it in a, if we just compile it, ASDs, VSDs, tricuspid diseases, and PDAs, they generally do well. So the mortality is less than 1%. NYHA 3 and 4, mitral stenosis with atrial fibrillation, atrial stenosis, and uncorrected TOF, these would come roughly in the 5 to 15% mortality category. And Marfan's, pulmonary hypertension, severe VSD, and Eisenmenger's, they would come with high mortality of something around 25 to 50%. And they're, almost a contraindication for patients if you are advising pregnancy.
Another very important population, patients with previous history of peripartum cardiomyopathy, and especially those patients who are having residual LV dysfunction after recovering from the previous episode, whose ejection fractions are less than 40%. They are at a very high risk of getting maternal events in the subsequent pregnancy, and also patients with aortic aneurysms, especially patients who are having aortic aneurysms with the diameters of more than 45 to 50 mm. So these patients have a maternal mortality of maternal event rates of around 40 to 100%. And in such patients, pregnancy should not be considered before having a corrective surgery for the same. And also patients having, as ma'am said, Fontaine surgery with complications, patients of tricuspid atresia, hypoplastic left heart syndrome who have undergone a Fontaine and now having atrioventricular valvular regurgitations. In such patients, maternal mortality is quite high, and corrective surgery should be considered before contemplating pregnancy.
Dr. Deebanshu, may I ask you one thing? What is Fontaine?
So Fontaine, basically, ma'am, in conditions where adequate pulmonary circulation has not developed, pulmonary blood flow is not coming. So what we do is we take the blood from the superior vena cava and the inferior vena cava, and we directly, to make it simple, we directly join it to the pulmonary artery. So bypassing the right side of the heart. So in that is a palliative procedure. That is not a definitive procedure. So patients usually require a corrective surgery later on in life and such patients usually have complications of arrhythmias later in life, which has to be treated well.
Okay. Thank you so much. So now this is what we as gynecologists should remember, because many patients will present with disorders, and whether it's normal or it is an exaggeration of normal or it is abnormal, that is what we need to remember. So what are the changes in the maternal hemodynamics in pregnancy? What is actually happening, Veronica?
Actually, in a normal pregnancy, everything rises. The cardiac output rises because as the pregnancies or the uterus is enlarging, there is blood pooling there. Inferior vena cava due to gravid uterus is also, and so the cardiac output as such, pressure to the heart is increased. Cardiac output increases, heart rate increases, stroke volume increases, because obviously if the cardiac output is increasing, it will give the stroke volume will be higher. Total peripheral, there will be a fall in the peripheral resistance, and the total blood volume as such also rises. Now what happens in cardiac patients having cardiac diseases, these changes are in fact increased. The cardiac output further increases because there is an ailing heart. I would just explain it in a very simple way. There is an ailing heart which is unable to take the normal. So anything which is unable to take the normal, it all those changes will be exaggerated in a patient suffering from cardiac disease, be it cardiac output, heart rate, stroke volume, blood volume. So these are the changes that will happen in a cardiac patient.
Okay.
I think
Dr.
what
Deebanshu, I'll come to you last.
yeah,
Wait.
no problem, no problem. Yeah.
Dr. Shikha,
Yes, ma'am.
yeah. Would you like to say something here?
Ma'am,
Any additional information?
ma'am, in this there is a cardiac output is also increasing during pregnancy. It's around 20 to 30%, and heart rate is also increased by 15 to 20 beats per minute. So this will ultimately complicate the pregnancy in patient with the heart disease. It increases the cardiac load, basically both preload and afterload also. And total peripheral resistance decreases. Blood volume also rises by 40 to 55%.
Dr. Varsha? Dr. Varsha? Ruchi ma'am, you'd like to add something here?
Yes, ma'am. Blood volume, it almost starts to rise as early as 6 weeks of pregnancy. And then it is rising right up to mid-pregnancy and peaking at around 32 weeks. That is one point. Second point is why is the total peripheral resistance decreasing? Because often we will see patients who were normotensive, they are coming to us with low blood pressure readings. It's only that 5 to 10% which is coming to us with high blood pressure readings, where we are saying gestational hypertension or pregnancy induced hypertension. The reason being because the progesterone that is increasing, it acts as a vasodilator. The prostaglandins, the atrial nucleate factor, the nitric oxide, and by itself the placental bed is a low resistance bed. So it's actually because the total peripheral resistance decreases, people come to us with a low BP. It's that one, just about a 10% chunk that comes to us with hypertension in pregnancy. And cardiac output, it can increase almost more than the 50% above the non-pregnant value. And the heart rate, it goes up to almost 10 to 20 beats per minute more than the normal non-pregnant status.
So back to Dr. Deebanshu, sir. If there's anything
Yes.
left that you want to add.
No, I think it's very well summarized by Dr. Ruchi and ma'am and the rest of the panelists. But I would just like to add, that cardiac output is what basically. So cardiac output is what you get when you multiply heart rate by stroke volume. So heart rate increases, stroke volume increases. How does it affect the diseases of the cardiac diseases? So patients who are having mitral stenosis, patients who are having aortic stenosis, these patients are really volume sensitive and heart rate sensitive. As soon as the heart rate increases, their LV filling time decreases, their left atrial pressures increase, and they have more chances of getting pulmonary edema. Whenever they have cardiac increase in the cardiac output, especially at around 32 weeks and immediately postpartum, because of the blood getting reabsorbed back into the circulation from the uterus, these patients are really prone to getting pulmonary edema, and these are the two stages when we as cardiologists and you guys as gynecologists have to be really watchful on the various parameters, and slight clinical signs should be very well picked up to prevent any such complications. And total peripheral resistance, as ma'am said, because of the uterus being a low resistance circulation, how and which cardiac diseases does it affect? It affects patients who are having Eisenmengers or patients who are having right to left circulation. In patients who are having mild right to left shunt, their shunt increases because of decrease in total peripheral resistance. So these patients can become more cyanotic who are less cyanotic initially. So all these things should be watched out for.
Okay. So we are sorted there. Now I come to another situation where Reena ma'am said, no, not every patient today who comes to us tells us that she has a history of cardiac disease. So a patient who is not a pre-diagnosed heart disease, how are you actually going to diagnose that she has heart disease? So start again with you, Veronica. How do we diagnose? What are the points in the history that we are going to
Yes,
ask?
any history where the patient is giving the first thing they will say any kind of dyspnea that the patient is having on rest. Usually, one thing I'll ask for dyspnea, then edema, any unexplained edema. Uh, After correcting for anemia, if the edema is not going even after adequate rest, these are the points that hint us towards an underlying cardiac abnormality that may be present. Then while examination, the first thing that should give a or arise a bell is the heart rate of the patient or the pulse rate also. At times an abnormal pulse rate or a heart rate, these are the things that we examine. Blood pressure, now blood pressure is something that also gives us a good indication. Some of the cardiac diseases may have varied pulses taken or varied blood pressures taken in sitting or supine position. So a good history where things are certain features are coming which are unexplained, followed by a good examination. Any history of previous decompensation in the past, where the patient may actually know or not know, but they will give a history of any hospitalization occurring due to these symptoms. These are the things, and then eventually any cardiac evaluation or any evaluation due to any other fact presenting feature which would have happened in the past in the non-pregnant state. So any abnormality in the ECG, previous ECGs that would have come. So these are the things which help us in clinching to going towards the diagnosis of heart disease.
One more thing that Reena ma'am said was use a stetho.
Yes, examination stetho.
Use a stetho and just try to listen into the maternal heart as well. We are so used to looking at the fetal heart with a Doppler, but that art of hearing the maternal heart is sort of being lost now. So, any addition to these questions, Dr. Nandini?
Yes, ma'am. In case of history, apart from talking about edema or dyspnea, we can ask her about her palpitations history, any syncopal history. Generally, aortic stenosis patient, they will present with syncopal history, palpitations history. Then any event happened in the past pregnancies. If she is a second or a multigravida, any event that she had to suffer in the past pregnancy, any ICU admissions she had. Then, if we are thinking of congenital disorder, we can ask her recurrent of respiratory tract infections, or if she has a family history of likewise. Then, in general exam, as ma'am has already talked about her blood pressure and all, when talk about aortic regurgitation, there will be wide gap between the diastole and the systole. And as you always say, as our professor also always say that when you auscultate heartbeat, just don't heartbeat of the fetus. Always put a stethoscope or just somewhere above in the mother's chest and always auscultate her heart. Also, that's a dictum. That it's not only important to see FHS, it is also important to auscultate her own heart also, because that's the best time you can diagnose. If the patient is coming around 8 months, that all the heart disease, most of the heart disease will be accentuated at 32 to 34 weeks of pregnancy. So you can easily diagnose and plan the mode of delivery where she has to deliver. So likewise, you can have.
Dr. Deebanshu, would you like to add something here?
I think all the points have been very well put forward by the panelists. I would just like to add, history of any, previous procedures done through the groin in the childhood or adolescence. Usually, a lot of the heart patients, they have some temporary palliative procedure which is done through the groin, like for coarctation of aorta. Sometimes you do a balloon proctoplasty. For severe mitral stenosis in adolescents, you sometimes do a balloon mitral valvotomy through the groin. And if such history has been taken by us in the past, then we can, evaluate them further by doing a 2D echo. And very well said that, when you hear on the auscultation any systolic murmur, they are usually innocent, especially in the pulmonary area. But murmurs associated with a thrill, when the murmurs are palpable by our hand, and they are diastolic murmurs, and they are continuous murmurs, with the exception of memory souffles that you get in pregnancy, which is physiological sometimes. All these things have to be kept in the mind. And pulse examination, whenever we have irregular pulse, we have to suspect atrial fibrillation, and we have to evaluate with the ECG and suspect and do a 2D echo and diagnose that problem. So all these things have to be kept in mind.
Ruchi ma'am?
I would like to share a story here. Most of the patients, they are coming with their in-laws sometimes, and they don't give you the history of this past episode. We had this kind of a patient. She delivered, she went home, she had an episode at home, she was hospitalized, and unfortunately, we lost her. So the maternal mortality rounds as conducted every month, I was called for that. And her in-laws were, her parents were also there. The girl's parents were there this time. And so, and the in-laws, they said, ki, as usual, they said, no, she did not have any pre-existing heart disease. But then when we questioned her parents, they told us that she had a congenital heart disease, which was treated, not treated, whatever, because she was from a very rural background. So these things also become important in front of your relatives. Sometimes the patient is not willing to disclose this information. So we should, in privacy also, we should be asking if we are suspecting it, if somewhere at the back of our mind it's there, we should be asking her in private also whether she has ever had a cardiac problem.
I think we as obstetricians need to learn that tact of talking to every patient in private. You don't know what information she's going to give you, whether it is past PID, past abortions, or, past illnesses. Some of them will be treated for a disease. They'll stop treatment when they get married.
Yes, yes. And thyroid is a very common disorder. They just stop the medication as soon as they get married.
So all of us need to talk to our patients in private, that is for sure. And now we come to the risk scoring. There are 3 scorings that have been told today. One is the NYHA, then there is the WHO classification, and then there is also the CAR-PREG. So for us gynecologists, Dr. Deebanshu, what do you think we should be following?
No, I think I'm very clearly NYHA is a classification which is meant for the functional class of the patient. It basically takes into account 3 or 4 factors. What is the dyspnea level of the patient? How soon is the patient getting dyspneic? What are the symptoms? Is he having any syncope, any palpitations, any chest pain? So NYHA1 is patients with heart disease having no limitation of physical activity. And 2 means they are having some limitations of physical activity, usually household work and everything they are able to do. but more than that, they get dyspneic, and then class 3 or ordinary physical activity also produces, such symptoms in them. And class 4 are the patients who are dyspneic and tachypneic even at rest. So this is a functional classification, and WHO classification is mainly according to the risk factors of maternal event rates according to the various subset of diseases. So I think you have to mainly rely on the WHO classification for pre-conceptional counseling of the patient, and then for further risk stratification, you can add on NYHA classification in this patient.
Okay, you were there when Lakshmi ma'am was speaking. So what about the Karpreg classification that she has said?
Yeah, Karpreg and Zahara, if I am remember from my post-graduation days, these were the two registries that we were taught also. So Karpreg and Zahara, they again they add on NYHA subgroups in those, and they take into some high risk factors like LV ejection fraction of less than 35%, cyanosis, oxygen saturation less than 30%, having subpulmonary, RV, right ventricular dysfunction. These are some of the factors that the Karpreg also, includes to make further risk stratification. So I think no one classification, it should be a combination of clinical factors and various classifications that should be taken into account.
Means I put forth a proposal that when a patient comes whom we don't know that she has heart disease, she's just walked into the OPD, and every patient should be assessed clinically, and then if there is any doubt, then you go ahead with initially the functional classification and then take it from there. Or anybody else wants to, offer something else? Ruchi ma'am?
I think functional is the easiest and for us to do as gynecologists.
More practical also.
So, yeah, more practical and easy to do. And as we said that it is a multidisciplinary approach. So the moment we suspect that there is something, we take the help of a cardiologist. Because I'm not very sure how good we would be at a Karpreg, because fine, NYHA, WHO we might be able to do, but NYHA is the easiest, simplest and most practical.
Okay. So now there's a patient with a congenital heart defect. If she is treated case, she has been treated and she has presented to you before pregnancy, during pregnancy, what is going to be your counseling? And if she's an untreated case, she's asking you a lot of questions, right? So how are we going to counsel her on different factors? She has a defect that is not treated. Veronica?
Ma'am, now counseling pre as well as during pregnancy is different in both the scenarios. Now, if she is a treated case, she has come to us, she is giving us the history that she is a treated case of whichever congenital heart diseases. The first thing that I would want to know is what is her heart status at present, how good the heart will be able to deal with the changes in pregnancy, and accordingly my counseling would be. If many a times what I have seen in my current practice is, usually these patients, if they are not on any medication initially, they are well compensated, so they usually tolerate pregnancy well. However, since they have that stigma of being in the high risk category, I would advise them to have a normal routine antenatal course, come for regular checkups, but be attached to a tertiary care center where we would be able to cater to her if any problem occurs during pregnancy.
So
And we have to
could
explain.
ask about the medicines that she's taking.
Yes, the drug history.
Yes, we have to ask the drug. That's what I'm saying. We have to ask whether she's on drugs or not. I mentioned in the thing.
If she has been treated, she's obviously going to be on something. She has a prosthetic valve or, she would be on something.
No, like some of the septal defects, if they have been corrected early, VSD and all, not necessary that they may be on any drug, but they are just on a regular follow up with the cardiologist. So I mentioned about that. I meant, and if valvular heart disease or something, if they have had a valve replacement, and then obviously they would be on drug. So the counseling, first of all, if they are on blood thinners, like if they are on acetrom or warfarin, my counseling will depend on that,
And then
what
we
they are
the
taking and
most,
what they need to take in pregnancy, how long they need to continue.
the
So
most important question they ask, बच्चे को भी तो नहीं होगा.
yes, so we
So-
have to explain them that risk of embryopathy, and we also need to explain them when all they have to take. I mean, from which duration to which duration they can be switched over to heparin.
But what are the chances of repeating a congenital disease? Because some congenital heart defects, they run in families and there are some that don't. So,
See, autosomal dominant diseases, like our Marfan's, our long QT syndromes, our Ehlers-Danlos syndrome. So they have a very high chance of getting replicated if the mother or the father has it. They have a 50-50 chance of the fetus getting that abnormality. On the other hand, a VSD, PDA, ASD, there's only 1 to 2% chance of the fetus having such an defect if the mother has it.
what about a bicuspid aortic?
Bicuspid aortic valve, I think the incidence is around 20-25% if the mother has it.
If the father has it?
If the father has it, I think it is less. It is lesser if the father has it, around 5%. Yeah.
Okay.
And even for TOF, Dr. Asha, we have to, because TOF, we have seen some micro deletions also. So if it's a baby with a TOF, then mother with a TOF, then we have to rule out certain micro deletions in the fetus also.
So here there are two questions. One is the mother herself when we are counseling, and the other is a treated father.
Treat mother.
So how does the risk differ if it is a treated mother or a treated father?
So for autosomal dominant diseases, it is the same 50-50 if the mother or the father is affected. Both carries a 50% risk.
So what
For
is an example of these autosomal dominant?
as I said, Marfan's is an autosomal dominant disease. Then some ECG abnormalities that give rise to arrhythmias like long QT syndrome.
QT interval.
These are some of the examples of autosomal dominant diseases. And hypertrophic cardiomyopathy is also a autosomal dominant disease. So they have a 50-50 chance even if the mother or the father has it.
Pulmonary hypertension?
Pulmonary hypertension, there is a very less chance of the fetus having pulmonary hypertension. It is around 2 to 3% only. And pulmonary hypertension itself, the pregnancy, patient is having severe PAH, there is very low
Usually
chance of the patient carrying on throughout the pregnancy
and
without
pulmonary
any
hypertension is one condition where pregnancy is contraindicated. So we usually,
severe,
so we have to counsel them to terminate the pregnancy.
I'm
severe
talking
PAH
if
is a
the father
contraindication.
has pulmonary hypertension. He's not getting pregnant, right? So what are the chances that the baby is going to get it? When they come
Minuscule.
for counseling, they're going to ask everything.
There's a very less chance, less than 1% if the father has it, or PH.
Okay. Now this patient is untreated because she saw no reason to be treated. A VSD, small ASD. So how is your counseling going to change now? She was asymptomatic, so she did not get treatment.
She did not get treated, so we have to counsel that all the symptoms, number one, will or may get exaggerated during pregnancy. We will have to tell her the signs and symptoms of decompensation. She has to come for early checkups, be under close observation. We have to also explain her the warning signs and symptoms, that is her management aspect, and also at the same time train and teach the relatives or the attendants also where they have to be careful.
Dr. Nandini, you want to add something here?
Ma'am, yeah, definitely. When she's untreated, we will have, as ma'am told, we have to tell her about signs and symptoms of failure also. She would be, she can, and she will. We have to teach her about the pedal edema of the sudden dyspnea, orthopnea, and we also, since we have been talking about the passing the same anomaly to the next generation, why aren't we talking about the fetal echo? We have to advise these patients at 24 weeks that have to undergo fetal echo essentially to rule out any congenital anomaly in the fetus heart, because definitely there's a chance for every congenital, most of the congenital anomaly to be transmitted to the next generation. That's
Ruchi ma'am?
Generally, small ASDs and VSDs, they sail through pregnancy, they do not have a problem. But if it's a large ASD, then the patient can land up with certain problems of CHF. In coaptation of aorta, definitely it's a very high risk case. So we have to explain all the possibilities to her, what she's going to land up with if she's been not treated for it. Eisenmensch's, as we said, again, very strenuous on the patient, high mortality rates. Marfan's, as we have already said, if she's coming to us at the late stage, we cannot do much about her. But if
Ma'am, here
pre-counseling,
we are talking about a patient who has actually no symptoms. She has come to you, you've diagnosed that this is an untreated case. Now we have to counsel and plan.
So we have to go through the whole NYHA, counsel her, take the
I
help
think
of a
first of all, I
cardiologist.
would want her to have a cardiologist opinion.
Yes, that's what I said.
That is the first thing I want to do. So over to you, Dr. Deebanshu.
Yeah. So, the lesser mortality, morbidity associated lesions, as everyone said, a small ASD, a moderate ASD, moderate VSDs, they usually go throughout the pregnancy without any complications. Again, the periods of increased cardiac output at 32 weeks and immediately post, you have to understand those periods and keep a close eye on them and explain that risk of CHF to the patient. But patient having a untreated tetralogy of palate, I would not personally, as a cardiologist, would want her to, continue the pregnancy because, it's a cyanotic heart disease, untreated tetralogy of palate, untreated other cyanotic congenital heart disease like Epstein's anomaly or a hypoplastic left heart syndrome. I would not personally want them to continue pregnancy, and I would strictly advise them to against the termination and continuation of pregnancy.
So we have a comment from Dr. Rimpi Singla that bicuspid at aortic valve, the risk of inheritance is 4 to 12%, not 25%. That is her comment that she has.
Okay.
So she's also from PGI Chandigarh. Thank you, Dr. Rimpi. And we know we have some really alert audience. Thank you so much. And now these are different conditions. And what are we doing? This is a quick recap. Mitral stenosis, mild, moderate, severe. How are we going to manage? One by one, we are going to take all of them in very short couple of sentences. Mild mitral stenosis, what's going to happen? Yes,
You can continue her like a normal pregnancy, usually well tolerated, right? And only when the severity increases to severe, because the valve diameter is very stenosis, there is an overburdened heart. Only in such cases, that is NYHA 3 and 4, that we really need to decide how to manage. Usually these patients go till term, and then the mode of delivery, whether cesarean, it depends on the severity and the condition of the patient then.
Okay. Dr. Deebanshu, you may put in the final word if you want to add something. Then I go to aortic stenosis to you, Nandini.
So mitral stenosis, it depends on the NYHA functional class and the symptomatic level of the patient. Asymptomatic mitral stenosis having a valve area of less than 1 is a class 1 indication to be treated before the pregnancy. So you have to either, if the valve is amenable to balloon mitral valvotomy, you have to put in a balloon and do a BMV. So if the valve is not amenable to balloon mitral valvotomy, and you have to plan a cardiac surgery before pregnancy. So you have to advise patient for
Okay,
putting
so
up a prosthetic
depending
heart
on
valve.
severity, you want her treated before she gets pregnant if it
Yeah,
is
yeah.
severe. Same for aortic stenosis.
It is same for aortic stenosis. Yeah.
Same for coarctation.
Coarctation you have to do if it is anything more than mild coarctation, you have to treat the patient before surgery.
Okay. Pulmonary hypertension is a contraindication. What about
Severe
aortic
pulmonary
regurgitation?
hypertension. Severe pulmonary
Ma'am,
hypertension is a
we have
contraindication.
had many cases of pulmonary hypertension.
Hypertension.
Yes,
Actually,
and
ma'am,
if
huh,
they are controlled, um, they can be taken up to a safer limit, or rather, I should say, 30 to 34 weeks of viability, because patients do not agree so easily for termination of
termination.
pregnancy. So, and we have had really good outcomes in some of these pulmonary hypertension women. So, this is what is our experience from our center.
Nandini?
Ma'am, actually, when we are treating stenotic lesion, many of them will land up in pulmonary hypertension later on. But as you are treating them, they are well and fine, and while they are near term, and if they develop pulmonary hypertension, then okay, it is all right. You can give a good outcome.
Yes.
It is not the not the
What
need that
about regurgitation? Is regurgitation good or bad?
gets better with pregnancy. All regurgitation lesion generally
Improves.
gets better.
Yes.
They are well tolerated in pregnancy as compared to stenotic lesion because of the decreased
Because
SPR.
Patient of regurgitation, if it's having severe regurgitating lesion before the pregnancy, and you have diagnosed it, you have to send the patient for a repair.
The advantage with regurgitation is because the peripheral resistance is reduced. So the forward flow is not getting much affected. So that is the way that regurgitation does not really harm you. But as Dr. Deebanshu said, if you severe and diagnosed early, should be repaired and before patient plans.
What about transposition of great arteries? If it is a CCTGA, okay, congenitally corrected, then what do you think is going to be outcome of the pregnancy? Not treated. It's a congenitally corrected, and the
outcomes they're usually good outcomes in CCTGA. The only problem is it is a systemic right ventricle in CCTGA. So there are high chances of that right ventricular failing. So if you have diagnosed on 2D echo that has right ventricular function is not good before the pregnancy, it is a high risk case. On the other hand, if it is without any complications, CCTGA, so you are usually tolerated well throughout the pregnancy.
Yeah, but the thing is, it's not a normal ventricle. It's the right ventricle working as a left ventricle. And therefore, the chances of even ventricular rupture are higher with that CCTJ. So how much load we want to give the patient, how much labor pains we want to give the patient, all this has to be very carefully managed over here. Now, this is a patient who had a cardiomyopathy and recovered with difficulty in her last pregnancy. After 2 years, she's conceived again. Now, what are you going to do? How are you going to counsel her and how are you going to monitor her? I'll come first to you, Nandini.
Ma'am, cardiomyopathy, if she has developed postpartum cardiomyopathy, will means in the last trimester, then the first 5 days of her postpartum period, will diagnose as PPCM, and it is a very it's because we will refer the patient again to the cardiologist. We will see her the what is the left ventricular function, actually the ejection fraction, what is the left ventricular function ability of the left ventricle is how much. Will decide her on pregnancy on that. We will counsel her first of all about all the complications she can land up into, and the sudden death she can land up into, and we will also counsel her about the medications that she is supposed to take. A diuretic, but okay, we will have to risk and benefit ratio has to be seen for prescribing diuretics in these patients.
No,
And
actually, my question is different. She had cardiomyopathy in the last pregnancy. Now she has come, she's just pregnant. She came with a UPT positive. She doesn't have cardiomyopathy right now. That cardiomyopathy was treated. She has recovered.
We
Now
need to
she
tell
has
her
come.
what are the various, I mean, the chances of going into a cardiomyopathy again is rather more in this pregnancy. We have to first explain her that, and then the period during which decompensation can happen. So this is something that needs to be told to her, and then an option to be given to her, whether she wants to continue the pregnancy,
Because
how
the
she wants to go ahead.
mortality in such cases, if she gets it again, are really high because it's the muscle, the cardiac muscle that is not really working. So, Ruchi ma'am?
Again, would like to share a story here.
Hmm.
Patient delivered IVF, twins, full-term delivery, cesarean section on demand, doing all well. Like she was operated today afternoon, and the next morning I did a round. She was all comfortable on oral fluids, and suddenly the staff came and told me that her heart rate has shot up to 132 and she's severely dyspneic. So I rushed and to see her room, and she was severely, saturation was only about 80, 78 to 80%. Pulse was 130, 140. So then we had a cardiac anesthetist around at that time. Dr. Deebanshu was not in city, otherwise I ran to him for help. So we had a cardiac anesthetist at that time, and he diagnosed it as cardiomyopathy, postpartum, peripartum cardiomyopathy. So then we shifted her to a cardiac center, and thankfully she recovered. So that was a like very sudden episode. She had no past history because you learn by burning your fingers. So I make sure that every term patient is getting an echocardiography done once earlier and once at term. So she did not have any problem, but we faced
And
this
usually
problem.
these patients, like ma'am was saying, they do not give time. They rapidly deteriorate.
Yeah,
You
I
hardly
don't
have
just
time
did
to
my
breathe.
round. I was sitting in my
Yes.
OPD, and the staff
Yes.
rushed to me, and I saw she was 78, 80% saturation. PO2 was that. And we managed to timely save.
Dr. Deebanshu, you want that patient to continue her pregnancy or you want her to abort?
No, see, we have to make the patient understand that there are around 20 to 30% chances that she might end up again having a peripartum cardiomyopathy, but the risk of having a subsequent bad outcome also develops whether she has fully recovered from the previous peripartum cardiomyopathy, not the symptomatic recovery, whether her LV ejection fraction is more than 55% after the first episode of peripartum cardiomyopathy. If that is the case, if after counseling the patient again, conception, she has conceived and she wants to continue the pregnancy after having a risk discussion with the patient, you can continue the pregnancy, but you have to be watchful. You have to give them serial 2D echoes at regular intervals to diagnose any deterioration in LV ejection fraction, and we have to start drugs like bromocriptine and beta blockers and diuretics if required at the right stage for such patients.
Okay. So now we come to the management. Everything else has been discussed. Only thing is the route of delivery. Obstetricians here, what route do you want this patient to deliver? Nandini?
Definitely a cesarean section under general anesthesia. We do not want her to exert.
Yes.
Not at all.
Okay. Veronica?
Cesarean section.
Ruchi ma'am?
No, I would, if she's a well controlled cardiac patient, there is no harm in a vaginal delivery because anesthesia has its own set of problems. We should not be forgetting that. So if she's a good candidate, yes, we can cut down the second stage of labor with a properly applied prophylactic outlet forceps or a vacuum. So because let's not think, okay, things have improved, but still anesthetic hazards to a cardiac patient, we cannot ignore that.
Actually, the guideline says that the cesarean would depend on the obstetric indication.
Obstetric reasons only.
It does not depend on the cardiac indication. And for cardiac indication, you need to do an epidural and take it from there. Even an instrument delivery is not as per guidelines. They say that normally cardiac patients have very easy deliveries. Somehow nature has given them that protection that most of the cardiac deliveries are easy deliveries. If there is an obstetric indication, because this is a panel and there are general people listening, we have to talk of the guidelines, and this is what the guidelines say.
And we
Okay.
have to avoid neutrotonics like ergometry.
You don't give ergometrin, that madam has already told.
Yes,
You don't give
misoprostol
ergometrin.
also, I guess.
You
Ma'am,
don't give
actually,
misoprostol.
anesthesia is better to give combined spinal and epidural instead of giving only epidural,
No,
isn't it?
no.
Yes, yes.
You give
Yeah.
epidural. Epidural for delivery. You give epidural
Okay,
for
labor
delivery.
analgesia. Okay, okay.
Labor
So that
analgesia.
she doesn't have pain, because pain will give
Immediately
tachycardia,
give.
that will lead to decompensation. So now we've discussed almost everything. One thing remains, that you lost the patient. Right? Now what are you going to do?
Dr. Asha, lost the patient as in?
You lost.
Oh, lost to follow-up or lost?
Patient lost.
Lost. Okay.
You have a negative outcome. The baby is alive, the mother is not alive. The classical movie scene. Now what are you going to do?
Have to clean.
Save the baby.
Come on, let's talk practical here. You have to check all your documents. You have to get medical help. And you need to actually review your documents yourself to see where you went wrong. That is the cause of the maternal review, right? That
Yes.
What was missed? What could have been improved to avoid a unnecessary death or a young death? That is why we do a maternal review. So 100% cesarean is not the answer. In the case where you have lost a patient, even in the low risk cases, Reena ma'am said something very important, that when it's a high risk case, everyone is so geared that usually the outcome is good. But when it's a low risk case, the outcome can go wrong very fast and you really have no time to do anything because you are not prepared. You're not prepared. You thought ye to simple case hai. This is not a compensated, decompensated, or it has had no problem. So in that case, whether it was just a rheumatic heart disease and she had an embolism and died, it's really not preventable. But there is something that we could have done better. That needs to be reviewed, and we need to look at the medico-legal aspect. Save yourself also. Save the patient, but save yourself as well. So I want a take-home message from each one of you before we end the session in 5 minutes. I start with you, Veronica. No, not with you. First with Dr. Nandini, who's the youngest.
I learned about Kespera classification. I also learned a lot of things from the cardiologist, and because ultimately managing the patient from him. And warfarin, yes, it is. I knew about it. It is dose-dependent embryopathy, and sir has also certified it, so we can give it in the meteorological period also.
Okay, Veronica.
Something that I learned from here is take a good history examination. Most of the thing is done over there, which helps you actually in planning your management. Cesarean is to be planned only in extreme and severe cases, and that too if there is an obstetric indication. That is what I learned. I mean, this was I have seen a couple of patients, and all have been planned. A couple of patients of cardiomyopathy, and most of them, I mean, they came in as very sick cases, and most of them have had. I do not remember if we have delivered any such patients vaginally.
See, when
So
I was
I
a PG
learned that.
student, there were so many cardiac cases. At that time, cardiac surgery was not prevalent. Rheumatic heart disease, congenital anomalies. If the patient is carrying you, most of the time, it's a very smooth and very short labor.
Yes.
We never gave so much. We never had vacuum at that time. Forceps was there, and that was also not needed in many patients. So that was inadvertent because we really had no option. You don't even have a cardiologist. There was no cardiologist in the city at that time.
So I agree to that. Most of the cases of stenosis, ASD, and the small VSDs, we are delivering vaginally. But then we have had a couple. I have had some 4 to 5 patients with Eisenmengers, I have even had a
That
patient
is
with
gone.
Takayasu's arteritis, right? Where apparently, I mean, till now I knew either pregnancy is contraindicated or it has to be delivered very closely. Cardiomyopathy. These are the common ones. So at least I learned today about cardiomyopathy and these high risk categories that even they could be delivered vaginally.
Ruchi ma'am?
I took a message from you. Hope for the best, but be prepared for the worst.
Yes.
So no cases to be taken lightly. Your arrangements should be in order. No cases to be taken lightly. And this warfarin aspect also I learned today. Of course, patients, they don't want any anomaly in the baby. So now whether it is 65, 35, I mean, you really have to counsel that well, because you never know when an anomaly might crop up later. So whether that is acceptable or not, how well you counsel and how well your patient is able to take that counseling. That is very important, because by low molecular weight heparin, we are all very happy with it. And I don't think we
Yes.
encounter much problem with it. But
Ma'am,
when for
actually,
warfarin,
most of the
No, ma'am,
patients,
but what Reena ma'am said was
yes,
very important. That
yes,
getting the INR has to be between 2 and
2
3.
and 3.
It
Right.
cannot be 1.3 and 3,
Right.
1.5 and you be happy with that. It doesn't
Yes.
work. So that is,
Yes.
and if you are really giving it in the full dose, it's extremely expensive. Not everybody can afford it. That
But
also has to be kept in mind.
ma'am, one
No,
thing
I
I
would.
would like to tell you on this, we have had lot of experience on these patients, and once you explain them, you counsel them at the first visits. We have not had a single patient who has not bought these heparin injections.
Patient
I mean,
will
these low
buy. Please
molecular weight.
understand. If it was so,
Yes.
convenient, they would have got treated. They
नहीं
don't
तो
get
वो
treated.
हम उन
वो
लोगों को
जमीन बेच के
वार्फरिन
कर
पे
लेते
स्विच कर
हैं. जमीन बेच के कर लेते हैं. So that is, we need to have better options for our country.
Yes,
That's
so
what I
we
feel.
tell
We
them
need
that
to
it
keep
is
our
only
eyes
for
open.
yes, we tell them it's only for a specific period of time. और 8th month में जब हम further switch over करते हैं तो it is only during that time. So
That is
all of
fine.
them
That is
agree.
fine.
Yes,
Yes, Dr. Deebanshu. I was talking about the whole of pregnancy.
No,
Not
that we don't give.
Yes,
No, I
Dr.
mean,
Deebanshu.
I
Last
think
take home from you.
the monitoring of INR has to be done only on patients with warfarin or acid ROM. For patients who are taking low molecular weight heparin, what the guidelines recommend is you have to, if you are giving only low molecular weight heparin without monitoring factor 10A levels, that is not correct according to the guidelines. So when you're giving low molecular weight heparin, you have to get a factor 10A level done 4 to 6 hours after a dose of low molecular weight heparin to see whether it is working on the patient or not, whether it is over heparinizing or under heparinizing, what is the effect. So blindly giving low molecular weight heparin also has led to increase in maternal effects on various complications and etc. So monitoring of INRs on warfarin and monitoring of factor 10A levels has to be done. And I must congratulate each and every one of the gynecologists over here for creating such a forum where everyone is with due diligence put in a lot of hard work on presenting cardiac diseases in pregnancy. The two previous speakers, I was amazed by how well their knowledge was of cardiac diseases in pregnancy, especially their practical knowledge about all these diseases. And I must congratulate each and every one of you for being on this forum and spreading more awareness on such diseases, which is the need of the hour. Thank you very much.
Reena ma'am, you are still here. Last words from you. So much. I thank you so much for being here till the end.
Yes, thank you. Because of my bad voice, I couldn't participate more. But I feel that cardiac diseases is a very important segment, although it is not that much percentage-wise. It is a huge cause of preventable death. And although we have experts in the cardiologist, finally the buck stops with the obstetrician. We are responsible for the patient and the outcome, whether it is good or whether it is bad. So we need to be vigilant, and we cannot say, oh, the referral has been done, so we will wait. For example, simple thing like furosemide or Lasix for heart failure. You give 10 milligram, 20 milligram, but if patient has gone into failure, you can go up to 1 gram. So these are small things. We as gynecologists should be on the ball and know what is being done. And so for emergency care, we need to be vigilant. So we will have a good outcome. And finally, to coordinate when it's a multidisciplinary approach, like you have an orchestra, you have to have one conductor who will wave the baton and see that the orchestra is working in harmony. Otherwise, anesthetists will say one thing, cardiologists will say one thing, then they will say, oh, maternal mortality hoega, to hamare under nahi rakhne ka hai. So the patient is finally under the obstetrician. So you are the conductor, you are the one who's going to wave the baton and see that things go well. That is my message. Thank you so much.
Thank you so much, ma'am. So thank you, Reena ma'am, Lakshmi ma'am, Ruchi ma'am, Veronica, Dr. Nandini,
Ma'am,
Dr.
it's a pleasure.
Deebanshu, and Dr. Alka ma'am, Sujaya, and all my viewers who have joined in. I thank all of you. And I hope we have all learned something today. And our evening on this auspicious Navratri evening is well utilized. Thank you.
ma'am.
Good night.
Thank you.
Shubh Navratri.
Thank you,
And
ma'am. Good night.
Thank you,
Good
ma'am.
night.
Thank you
Thank
so
you.
much.
And a special thanks to you also for keeping this topic.
Yes.
Yes, very relevant.
Thank you so much. Shubh Ratri.